Hi, I'm Wendy Uhlmann, and I am a clinical associate professor in the departments of internal medicine and human genetics. I am the genetic counselor, clinic coordinator of the Medical Genetics Clinic at Michigan Medicine. My disclosures are on this slide. Key terms that I will be using are on this slide. And the lesson outline, I will be giving an overview of genetic testing, talking about different types of genetic tests, uses of genetic tests, complexities of genetic testing, and ethical issues. The learning objectives are that you will be able to define genetic testing, describe types of genetic tests and their uses, and describe complexities of genetic testing, including key ethical issues. Genetic testing is used to establish, confirm, or rule out a diagnosis, to determine carrier status for a genetic condition, and importantly, to enable cascade screening of at-risk family members after familial mutation is identified. Results can be used to inform healthcare and life decisions. For example, someone may use genetic test results to make plans about having children. Genetic tests are different from other medical tests. Medical tests are done to detect a current medical condition, whereas genetic tests may be done on a healthy individual to determine future risk for a genetic condition. And this type of testing is known as predictive genetic testing. Genetic tests may need to be performed on an affected family member before an asymptomatic patient can be tested. Genetic test results may have implications for healthcare and life decisions of other family members. There can be psychosocial impact of genetic test results, and there are possibly insurance implications and potential for stigmatization and discrimination. Given the complexity of genetic tests, genetics expertise is needed to assess what is a patient's risk for a genetic condition, to determine if genetic testing is indicated and available, to select the genetic test and lab, interpret and communicate results, and determine the implications of the genetic test results for the patient and their relatives. I'd like to turn now to the definition of genetic testing and types of tests. Our genetic information is packaged into structures called chromosomes, which are found in the cells in our bodies. The chromosomes are made up of smaller units called genes, and the genes are what code for proteins. So you can think of it as chromosomes to DNA to proteins. Genetic testing is an analysis of chromosomes, genes, and/or gene products to determine whether there is an abnormality present that is causing or will cause a genetic condition or disorder. Biochemical tests assess for the amount of activities of proteins and enzymes. Biochemical tests are often used for newborn screening. For example, biochemically you can measure the amount of phenylalanine, and if there's excess phenylalanine, that would be indicative of phenylketonuria, which can result in intellectual disability if not treated. Chromosome analysis has been a mainstay in genetic testing for several decades. And chromosomes can be analyzed for changes in number, whether there's more or less than 46, and also they can be analyzed for structure to look for changes including deletions, duplications, and rearrangements such as translocations and inversions. Examples of these types of changes are shown on this slide. On the left, you can see that there is an extra chromosome number 21, so 47 chromosomes are present, which would be indicative of Down syndrome. And then on the top, middle, and right, you can see an example of a chromosome deletion, where there's a segment of the chromosome that's been removed, or on the far right, a segment of the chromosome that has been deleted. And then on the bottom photo, you see a picture of a translocation, where you can see a segment of chromosomes has been exchanged between two chromosomes. Fluorescent in situ hybridization involves using fluorescent probes that adhere to specific DNA sequences on chromosomes to determine the number of copies present. And it's used when clinical features are consistent with a well-described microdeletion or microduplication. For example, having a deletion of 22q, which can result in DeGeorge syndrome. It's also used when characterization of a specific structural chromosome abnormality is needed. Chromosome microarray analysis, also known as CMA, is used to assess for copy number variants to identify chromosome microdeletions and microduplications. And this test now is actually a first-tier test for individuals with multiple congenital anomalies that are not specific for a genetic syndrome, for autism spectrum disorders, and for non-syndromic intellectual disability. It cannot detect chromosome translocations, inversions, or mosaicism, low-level mosaicism. And what you see on the right is how this test is done, using a sample of a patient's DNA and control DNA and looking for microdeletions and microduplications. The yellow colored would mean that there's an even amount of patient's DNA and control DNA present, whereas green would indicate that there's duplicated patient material, and red would indicate that there's deleted patient material. Where there's been the biggest growth in genetic testing has been with DNA-based tests. And as you can see there, I have a reference sequence, and then I'm showing a change in the patient's DNA sequence. And gene sequencing can be done to identify base substitutions and small deletions and duplications. For example, looking at the presenilin-1 gene for early-onset Alzheimer's disease. We can also do targeted mutation analysis. This is also known as single-site testing, where there's testing for a specific familial pathogenic or disease-causing variant. For example, looking for the specific change in the presenilin gene of a C to a T. There also is mutation testing, which can be done where you're looking for a panel of common mutations in a single gene. For example, looking for the 23 CFTR mutations for cystic fibrosis. So this is an example on this slide, again, of single gene testing. But there have also been advances where we can now do multi-gene panels. So for example, simultaneously examining multiple genes. For example, for early-onset Alzheimer's disease, looking at a panel of presenilin-1, presenilin-2, and APP genes. Deletion duplication analysis is a test that can be done for a single gene or multi-gene panel, and it's used to assess for deletions or duplications causative for a condition. For example, for Duchenne muscular dystrophy, most of the time it's due to a deletion or duplication. So you would want to start with deletion duplication analysis, and if negative, then you would do sequencing. Alternatively, if you've done sequencing for a gene that is negative and your suspicion for a condition is high, then you would consider doing deletion duplication analysis. And where there have been the biggest advances in genetic testing now is what we call genomic sequencing, where you can analyze the sequence of all protein coding genes, whole exome sequencing, and if non-coding regions are included, this would be called genomic sequencing. And these exome and versus genomic sequencing are illustrated on these pictures, and you can see that with whole exome sequencing, we are sequencing only the exons, which are the coding regions of the genes. And that's what's shown on the right side of the first picture. On the left side of the picture, you're seeing genomic sequencing, which would be looking at both the exons and sequences in the introns as well. And over on the right, I think it's another good way to think about this is that with whole exome sequencing, which contains, is 1% of the whole genome and is where the vast majority of protein coding genes are, is that it's like looking at a segment of an orange, whereas whole genome sequencing is looking at the entire orange. And genomic sequencing has been possible in these next generation and multi-gene panels as well due to advances with next generation sequencing. And this high throughput DNA sequencing technologies allow for rapid sequencing of large numbers of DNA segments up to and including entire genomes. Current applications of genomic sequencing, and really this is referring more to whole exome sequencing, which is more what is being used today. Genomic sequencing is really just being introduced. So I'm referring here more to whole exome sequencing, and this is being done on diagnostic odyssey patients, patients maybe that have had symptoms unknown and have had other testing done that has not yielded a diagnosis. It's also used when there are many possible differential diagnoses, and it's more cost effective than testing genes individually. When there's limited or no comprehensive test available for a suspected condition, or when there's an atypical presentation of the genetic disorder. So what I'd like to turn now to are the uses of genetic tests. First off, there are different samples that can be used for genetic testing, including blood samples, skin samples, chorionic villus sample, which is what you see in the top right picture. That's a prenatal procedure that can be done starting at between 10 and 12 weeks gestation. In the middle row, you can do cheek swabs, and I'm also showing amniocentesis, which is another prenatal procedure typically done after 15 weeks gestation. And the bottom photo shows pre-implantation genetic diagnosis. And then on the right, it's even possible to get a sample for genetic testing even using mouthwash preparation. There are different uses of genetic testing, which are shown on this slide, and I'm now going to talk about some of these. So genetic testing is currently offered to individuals with symptoms consistent with a genetic condition to establish, confirm, or rule out a diagnosis. And on the top right photo, you see an individual with Down syndrome, and to the right of that, you see an individual with Huntington's disease. It is also offered to individuals that have a family history of a genetic condition. For example, having a family history of Huntington disease. There are genetic tests that are currently offered on a population level, and this includes newborn screening, carrier screening, multiple marker screening for pregnant women, and prenatal testing. Diagnostic testing is used to establish, confirm, or rule out a diagnosis in a patient who has symptoms suggestive of a genetic condition. Carrier testing is offered to individuals based on their family history of a genetic condition or due to ethnicity. If a patient is identified as a carrier, testing the partner can be offered to determine if a pregnancy is at 25% risk. Prenatal testing may be an option. This slide is showing carrier screening by ethnicity and shows the carrier frequency for cystic fibrosis, sickle cell anemia, and Tay-Sachs disease. When both parents are carriers for the same genetic condition, there is a 25% risk to have a child affected with the condition. Prenatal testing is offered during pregnancy to assess fetal status when there is an increased risk of having a child with a genetic condition due to advanced maternal age, family history, ethnicity, abnormal screening test, or ultrasound or abnormal ultrasound evaluation. As I noted in the previous slide, chorionic villus sampling is a first trimester prenatal diagnostic procedure. Amniocentesis is a procedure that can be done in the second trimester of pregnancy. And I'm showing a blood sample because it's now possible to take a sample of the mother's blood and using the fetal cells in maternal circulation to be able to do some tests on that as well. So pre-implantation genetic diagnosis is used with in vitro fertilization and involves genetic testing of an early embryo prior to implantation. Non-invasive prenatal testing, this is the test I was talking about where you can take a sample of the mother's blood to screen for specific fetal chromosome abnormalities, and this is usually done starting at 10 weeks gestation. Chorionic villus sampling is next shown and typically done between 10 and 12 weeks gestation, and amniocentesis typically done starting starting at 15 weeks gestation. Turning to newborn screening, this is mandated by law in all of the states, and it was initiated in the 1960s. Newborn screening screens for genetic disorders which can result in severe medical problems, intellectual disability, or even death in newborns. Some of the conditions can benefit from early treatment, like having a limited protein diet for phenylketonuria, which is a condition I discussed earlier. States differ in newborn screening, and on the left I've included a database that you can go to learn what conditions are screened for in different states. And here in Michigan, I've shown on the right that we screen for 50+ disorders and hearing loss, and you can see that there are 2 conditions that were in fact added to that list in 2017. Predictive testing is offered to asymptomatic individuals with a family history of a genetic disorder, for example, early-onset Alzheimer's disease. And early-onset Alzheimer's disease often occurs before age 55. It accounts for about 3 to 5% of all Alzheimer's disease cases and follows an autosomal dominant pattern of inheritance, which means there's a 50% risk to inherit the gene mutation if a parent has it. And this was portrayed some in the Still Alice movie, and it's very different to test someone that is symptomatic like Alice versus testing her daughter. And the limitations of predictive genetic testing is it can determine whether a pathogenic variant, disease-causing variant, has been inherited, cannot determine the age of onset, severity, or disease course. Why someone might consider predictive testing is to make life decisions, which are listed on this slide. And as you can see on this next slide here, there are reasons that people choose to be tested, and likewise reasons people choose not to be tested. And it's really the patient's choice to be tested, and that their values and preferences need to drive their decision about whether or not to have predictive genetic testing. Because remember, predictive genetic testing is being done on a healthy individual to predict a future risk. And someone may want to know that information, someone may not want to know that information. And so that's why it's important to explore with patients the reasons for testing and potential implications of results. There are international guidelines for predictive genetic testing for Huntington disease that have been adapted for testing for other genetic conditions. Turning now to the complexities of genetic testing, it's important to remember that just because a gene change has been identified does not mean a person will go on to develop the condition. And therefore, thinking about genetic testing in general, ordering a genetic testing is not as simple as checking off a box on a form. Pre-test counseling, informed consent, and post-test counseling are critical when ordering and thinking about genetic testing and thinking about implications of results for both the patient and relatives. And I've included on this slide here different components of pre-test counseling, informed consent, and post-test counseling. In terms of finding practice guidelines for genetic tests, I'm showing here on this slide 2 resources to locate this information. Determining the genetic test to order depends on the type of change you are looking for, as illustrated on this slide, which is why genetics expertise is important for making the determination of which test to order. Selecting the right genetic test requires accurate pedigree analysis and risk assessment, and determining who will be most informative for testing. It may not be the patient seated in front of you, but one of their relatives. Knowledge of different testing methodologies and their limitations is needed to select the right test. And searching genetic testing databases is needed to find tests and to compare tests and then to make test and lab selection. And the Genetic Testing Registry is an online genetic testing database that can be used, and you can see that you can search by tests, by the genetic condition, by a gene, and by labs. And Gene Reviews is just a resource to learn more about the genetic condition and genetic testing. So selecting the right genetic test is critical, and it's important to figure out whether you're going to be ordering a single gene test, a multi-gene panel, or doing genomic sequencing and possibly deletion duplication analysis. The important thing to keep in mind is that laboratories may use different methodologies even when testing for the same genetic condition. And tier and reflex testing may need to be considered. The challenges of genetic testing include the fact that testing for many genetic conditions is not yet standard of care. And in fact, few practice guidelines exist. Many genetic tests are costly, and generally insurance pre-authorization is needed. Many genetic tests have low detection rate, and so delaying testing until advances are made may be beneficial. It is a moving target right now with genetic testing with rapid evolution of information. And genetic testing may not yield a yes or no answer, and the significance of a result may be unknown. Possible genetic test results include, having a positive result, identifying a pathogenic or disease-causing mutation in a gene, a negative, where a change is not identified in gene, and you have to be able to distinguish between a true negative versus a negative result, and I'll have a slide on that in a moment. Given the newness of this test, of many genetic tests, what we are finding these days are what we call variants of uncertain significance. Meaning that a change has been identified in the DNA sequence, but its significance cannot be determined. It is not known when there's a variant of uncertain significance whether it will turn out to be benign or whether it will turn out to be pathogenic. And that's what I'm showing here on this slide. Again, having that DNA change in the DNA sequence and the fact that you can have no mutation identified, a benign or likely benign gene change identified, the variant of uncertain significance, or having the mutation or having the variant classified as likely or probably pathogenic or pathogenic. Turning to the limitations of a negative result, what you see here on the left is an individual with Alzheimer's disease who has a presenilin-1 pathogenic variant. Their daughter at 50% risk has tested negative for this presenilin-1 pathogenic variant. This is considered a true negative result because the daughter has tested negative for the variant that was identified in the affected parent. On the right, this is a negative result with limitations because the affected parent has not been tested. Therefore, we do not know if the parent has a pathogenic presenilin-1 variant. The affected parent may have a pathogenic variant in a different gene, and the affected parent may not have a pathogenic variant identified with today's technology. Therefore, the daughter, although she has a negative result, we cannot say for sure that she will not develop Alzheimer's disease because we do not have the results on the affected parent. It's also important to bear in mind that when we see a gene change, it does not necessarily mean an individual will be affected. And the arrow is pointing to the individual who is 58 years old, who does not have the genetic condition, but as you can see, passed the gene change on to their son, who did develop the condition. And there are other factors shown on the right that can modify the effects of a pathogenic variant and how significantly a individual will manifest symptoms of a genetic condition. This whole notion of when is a test ready to be a test is challenging in terms of tests rapidly moving from research to clinical application. When variables such as those shown on this next slide in terms of analytical validity and clinical validity are still being sorted out. And it's particularly challenging for rare genetic conditions to be able to obtain data on the variables shown on this slide. And this is, in fact, very, very true, especially with genomic sequencing. The promise and challenges of genomic sequencing include the fact that when we do sequencing, we're not just sequencing for the condition that the patient is being evaluated for, but we have the potential to identify what we call secondary variants for genetic conditions. So for example, you could be testing a child for intellectual disability, and you may identify a BRCA1 pathogenic variant, indicating that the patient is at increased risk for hereditary breast cancer. In addition, with genomic sequencing, we are also identifying a greater number of variants of unknown clinical significance. It is very labor and time intensive to do the genomic analysis and to search scientific literature and databases in order to interpret variants and weigh conflicting information. On this slide, I've just showed just some examples of different databases that are used in variant interpretation. And this is a very time-involved process to search these databases and weigh the information. There are a number of issues to consider in terms of what secondary results should be disclosed: all, none, some, and who should decide this? The lab, the clinician? What role should the patient have in terms of determining what they want to know or not know? The American College of Medical Genetics and Genomics has provided some guidance in terms of stating that there are results from 59 what they consider medically actionable genes that should be returned. So for example, gene changes for hereditary cancer syndromes and hypertrophic cardiomyopathy. Patients are informed that there are medically actionable genes, but are also given the opportunity to opt out of knowing this information as well. And you can learn more about genomic sequencing through articles at this website. Turning to some of the ethical issues with genetic testing, there are broader insurance issues. Genetic tests can be costly and may not be covered by insurance. And depending on the genetic condition, test results could impact health insurance, life insurance, disability insurance, and long-term care insurance. The Genetic Information Non-Discrimination Act, GINA, was passed in 2008, which prohibits health insurers from requesting or requiring genetic testing or using genetic information to determine eligibility or establish premiums. Similarly, there are also protections with employers as well. To learn more about the Genetic Information Non-Discrimination Act and to learn more about state laws, I've included resources on this slide. It's important to keep in mind when you do genetic testing that it's not just a blood test and that results can have significant personal and familial implications, as noted on this slide, because you share 50% of your genetic makeup with your first-degree relatives, which are your parents and siblings, 25% of your genetic makeup with your nieces and nephews, aunts and uncles and grandparents, and 1/8 of your genetic makeup with your first cousins. Therefore, if any of these family members have a genetic condition, or if you have a genetic condition, it's going to have implications for family members. And as a result, it's important to recognize too that the existence of genetic information within a family, as noted here by Lori Andrews, can create or destroy bonds between relatives. And as you can see above, that genetic information can have different psychosocial impact on the individual and potentially the family members as well. Genetic testing can also raise ethical issues in terms of thinking about testing a pregnancy or testing minors. There are position statements and professional guidelines. For example, the National Society of Genetic Counselors states that for considering genetic testing of minors for adult onset conditions, that such testing should be deferred when results will not impact childhood medical management or significantly benefit the child. In terms of prenatal testing for adult onset conditions, the National Society of Genetic Counselors encourages deferring this testing if the pregnancy management will not be affected. There are many other ethical issues with genetic testing, which I do not have time to present here, but are listed here on this slide. It's important when faced with an ethical issue to access practice guidelines and position statements if they exist, to evaluate the locus of decision making and carefully determine risk and benefits, and to have careful assessment of whose rights take precedence when there is a conflict, and importantly, to consult with an ethics committee if available and as indicated. Just because a genetic test exists does not obligate its use, and it's important to remember that a genetic test is not the same as having a genetic evaluation. I've included on this slide directories to genetic clinics and clinicians. In summary, genetic tests analyze chromosomes, genes, and proteins. DNA-based tests include single gene, multi-gene panels, and genomic sequencing. Genetic tests have multiple uses and are done on symptomatic and asymptomatic individuals. Genetic testing labs may use different methodologies with different test sensitivities, even when testing for the same genetic condition. Therefore, test and lab selection requires genetics expertise and careful consideration. Genomic sequencing increases the ability to identify gene changes, but raises challenges with interpretation and determining results to disclose. Genetic testing can raise ethical issues. Risk assessment, pre-test counseling, informed consent, and post-test counseling are key components of genetic testing.